Everyone, welcome to today's webinar from the SPSP Acute Adult Deteriorating Patient Programme. We'll just be allowing a couple more minutes for people to join and then we'll get started, okay? Okay, welcome everyone to today's webinar, which will be running till 3:30. This is part of the SPSP Acute Adult Deteriorating Patient collaborative webinar series. And today we're going to be focusing on using e-observations to recognise and respond to deterioration. Okay, so next slide, please. As per any Health Improvement Scotland meeting, I'm sure you'll all be used to this. Just to save everyone's peaking bandwidth, I'd be really grateful if, when you're not presenting or speaking, if you could turn your camera off and keep yourself on mute as well. As we go through the presentations today, our Q&A is a combined Q&A at the end of the session. But once we get to that, if you do want to make a point or raise a question, then feel free to put something in the chat or to raise your hand. Okay. If there are any technical difficulties, Sarah from his team is on hand to help, and you can either contact by messaging the chat or emailing at his acute care email address that is on the screen there. Okay. So the aim of today's session is to really share learning from 3 of our health boards, NHS Fife, NHS Lothian and NHS Lanarkshire, regarding the different approaches they have taken to the issue of developing electronic observation systems. And you'll hear 3 stories from 3 good friends of our programme about how they've gone about implementing electronic observations, and they're all at slightly different stages in this whole process as well. So hopefully that will be really useful to yourselves who've already implemented systems, or also useful to you if you're planning to implement electronic observation systems. We'll touch on the benefits and challenges regarding these systems as well across NHS Scotland. Okay, so next slide, please. So to delve into the programme, I'll kick off with a bit of scene setting around approaches that have been taken outside Scotland. And then it's my good friend Gavin Simpson, fellow intensivist from South East Scotland, talking about the well-established eObs system in NHS Fife. Nicola Maran, a consultant anaesthetist at NHS Lothian, will then talk about the system in NHS Lothian, which is launching essentially as we speak in NHS Lothian. We'll have a short break, And then to bring it all together, we're really pleased to have Karen Goudie from NHS Lanarkshire, who will talk to us about their experience of the patient track system. After that, we should have good Q&A, and I can see there's lots of you on the call who could well contribute to that Q&A, and we're expecting to be joined by other colleagues who've contributed a lot to eObs across NHS Scotland, such as Gillian Macaulay, Acute Nursing Director at NHS Lothian, who I think has led the NHS Lothian programme and has also been heavily involved in the Lanarkshire programme as well. And to close, we'll just talk about a few learning events that may be of use to you coming down the line from the SPSP programme. Okay, so electronic observations is incorporated into our SPSP, Acute Care Deteriorating Patient Collaborative. And I've not put our driver diagram up there, but it's one of the ways in which we can think about improving our electronic observations. I'll leave it to the speakers to say how why that might be effective, but it's interesting to reflect about this is an issue that's being challenged in many other healthcare systems as well. I have to say, for my own part, my first consultant job was in some time ago now in NHS England in Nottingham, and we implemented an electronic observation system down there. And if you look at NHS England as a whole, many trusts have used different systems to electronify their use of News 2. Interestingly, I was recently at the Deteriorating Patient Conference in June in Dublin, hosted by the Health Service Executive in the Republic of Ireland. And they've taken a slightly different approach to both NHS England, but also NHS Scotland, in which they, in their public hospital sector anyway, have taken very much a centralised approach. They've launched their iNews, which is very similar to News 2, as a scoring system across all their public hospitals and have a national standard in terms of observation frequency. They also have a plan to launch one single electronic observation system across their acute hospitals, and they've trialled that in Gavin General Hospital in the north of the Republic. And it was really interesting to hear their kind of initial pilot study and the effects they've had in terms of their uses of electronic observations. Some of the challenges may be very similar to the ones that you're about to hear about from the speakers, but there's also some of the benefits, such as the effect on nursing workload and potentially freeing up time to care. So it's interesting to think about those different approaches. If we go into the next slide, that one solution for Scotland ship may well have sailed, and as you know, if we look at the use of electronic systems across across Scotland, there is huge variation whether we look at electronic records and now electronic observations. And you're going to hear three slightly different stories about three different projects from our boards. It's worth saying and just highlighting that we are currently, and some of you on the call are involved in this process, revising and rewriting the SIGN 139 guidelines, which deal with patient deterioration. The original guideline was a consensus statement. Largely, we're currently looking at all the evidence, and the revised SIGN 139 guideline will look at the deteriorating patient in both the primary care and the secondary care setting. But certainly, part of the process of revising the guideline, we are certainly looking at electronic solutions in the various aspects of recognising, but also escalating care for the deteriorating patient. So in that context, we're really pleased to welcome our speakers today. If we go into the next slide. I'm very pleased to welcome our first speaker, Gavin Simpson. In addition to being a very active member of the South East Scotland intensive care community, Gavin has been a consultant at NHS Fife since 2009. He has led their cardiac arrest group for some time, and the work around recognition but also review of cardiac arrest in NHS Fife has been kind of well publicised across Scotland. In addition, Gavin has spoken for many years about their eObs system, which I think has been in place since 2012. He has a huge amount of experience and probably the most experience in leading such a programme in NHS Scotland. So we're really pleased to hear what he has to say about eOb reflections from NHS Fife. Over to you, Gavin. Thank you very much.
Gregor, thanks for welcoming everyone today. It's been it's great to be invited along to talk to you all. So thank you very much for the invite. And thanks for the layout of the afternoon. It's going to be good, and I'm going to be really interested in speaking to everyone a bit later on about everybody's experiences and opinions. I have been asked today, as Gregor pointed out, that we've been doing eObs in Fife for a long time, and we initially started the project way back, you're quite right, in 2012, rolled it out holistically to all the acute adults in 2015, and then latterly we've gone on to all our community hospital beds recently in the last couple of years. And so I was asked along today to not talk about the installation and how we rolled out as a QI project initially, and good colleagues Nikki, Maran and Karen Goudie are going to speak a little bit later on about their experiences, but I've been asked to talk a little bit more about the bedded in advantages maybe of having an eObs system. And so I've only got a few slides, but I'm going to talk to some of them. So if we could go to the next slide, please. In order to do that and maybe to lay out the afternoon and the benefits of eObs, I suppose we need to know the fundamentals of deteriorating patients. So forgive me, because I know there's a number of seasoned experts in the crowd today who probably look at this and recognize it and say, well, that's obviously what we need to do for deteriorating patients. But the logic of having an eObs system is on the basis of the fundamentals of about how we identify and manage our deteriorating patients in our hospitals. And this is a very distilled down snapshot of maybe how we manage our deteriorating patients, and we look at an outcome in SPSP of our cardiac arrest as a raw outcome, but we also want to know about our processes leading up to how we manage our deteriorating patients. But if you take in principle what we'd like to do for any deteriorating patient, and if you accept that maybe anyone that we feel merits to be admitted to a hospital is potentially deteriorating by definition, i.e. we wouldn't admit them otherwise because they'd be fine at home, but we decide this patient needs to come in to be observed, to be diagnosed and to be treated, or they will continue to carry on in that trajectory of deterioration, then ultimately we can extend that and say, well, if we left them in a hospital bed and didn't observe them and didn't do anything to them, then they might deteriorate further, and eventually they might end up having a cardiac arrest. So what we've done for years, since early warning, well, since observations came along, since we started taking pulses on patients, we decided to take observations and make a judgment call about whether that patient's stable or getting better or not. And then what we like to do with those observations is distill that down. And early warning scores were created 35 more years ago now to try and simplify those physiological observations into a single number to make sure that we could communicate those early obs, those complex interplay of observations in a meaningful way, so we could just create a single number, so we could phone someone up and say, listen, we need help because this person's single early warning score is very high, therefore we need help. And then what we want is, once we've called for that help, is to get a medical response with a plan. And if we boil that plan down into simple terms, we want to do one of three things, and that's triage. And Gregor talked about that at that last webinar and SPSP conference, saying that triage is important. And what we'd like to do for any deteriorating patient is get them to an area of higher observation, maybe in HDU or ITU, or maybe this person has had every intervention tried, and a large proportion of our patients, unfortunately, we have no interventions left, or we've tried everything we can, but we need to focus on the well-being and dignity of this patient. But they might need a DNA CPR or a TEP or an ACP because this person might be dying. Or we manage that patient in situ, and we manage that patient on a ward with treatments, with interventions, and we hope that patient gets better. But in all three of those circumstances, what we do if we admit them to ITU and HDU is stop taking observations, and therefore they're on a different observation protocol with continuous observations. Or if they're DNA CPR and ACP, maybe we want to carry on doing observations but not alert and make phone calls for medical plans because we've got one in place. Or indeed, if we get that patient better, then hopefully their OBS will improve. So that's very simple, but it seems to make common sense, and that's what we're trying to do for all our deteriorating patients. The question is, can we simplify this even further? And if we go to the next slide, there is a possibility that we could simplify that diagram even further into detecting our patients, whether you want to do it by taking their physiological obs and an early warning scores, and then we can have an action, and that action can be the medical plan, the treatments, the intervention, whether that's an outreach team, EAMP teams, junior doctors, whatever it may be in our hospitals. But you can detect as many patients as you want, and you can have the most robust action plan in a hospital written down and protocolized with an SOP and all sorts of teams that can go out to see these patients and do what you need to do to triage these patients. But the missing link is the key ingredient here that's extremely important, or nothing will work, and these patients will not be triaged, and these patients will continue to deteriorate. And if we go to the next slide, you'll see that the missing ingredient that's really important is the communication. If we don't get the communication absolutely spot on between the detection and the action, you can have the most robust detection system for taking OBS, and you can do them diligently every minute of every day, and you can have the best action teams. But if the best action teams and action plans don't know where the sick patients are, those patients will not get treated, and they will not be triaged, and they'll continue to deteriorate. So if we could go to the next slide, please. This is where the benefits, I suppose, of eObs come in, and it's maybe the unseen missing ingredient for many of the systems that we have in hospitals for picking up and acting upon our deteriorating patients. And if we don't know about that missing link and we can't measure that missing link, then we sometimes scratch our heads saying, well, we've got great ops systems and we've got great teams that can go out and see these patients, but actually we're still not improving, and the question is why. So eObs systems are a very simple communication tool, and that's it. And it's communication in the modern era, really. And there's a whole bunch of benefits. But in simplicity, what it does is now all the nurses and auxiliary teams that take observations for our patients in a hospital put them into handheld devices in our hospital. And the eObs hospitals, and those are converted immediately and automatically without any mathematical error. You may take the wrong OBS, but the maths of adding up the individual OBS is error-free and gives you a score that's visible. And then what it does is it alerts automatically, and we can send out pages automatically to people's phones or pagers to say, Mr. Johnson, Bay 4, bed 4 has an early warning score of 6, please respond. And that suddenly flips the dynamic of nurses in the middle of the night on busy wards with 10 patients to look after, going to a phone, paging someone, hoping that someone will respond, and hoping that that medic or other at the other end of the phone aren't equally busy, and get back to them immediately to come and have a conversation with them about how sick their patient actually is. So that automatic addition takes away an error rate. In our hospital, it was about 9% of some of the mathematics of just adding up the scores. It automatically alerts and communicates out on an individual basis, traditionally between the person taking the OBS and the person who's meant to introduce the action plan, and gets that message out in a holistic zero tolerance way to some extent, in that every set of OBS is taken. But the communication goes a step further than that. It's not just individual one-to-one communication. Some of the benefits of an eObs system is that you can take that one set of OBS, and once it's in the system, once it's put into the handheld device, whatever way that may be, the communication suddenly extrapolates up the way and goes exponentially increases the power of that data that is now a single data point. And rather than relying on somebody making a phone call to an individual one other, that data is there for anyone to see anywhere in the hospital. And what I mean by that is we have traditional traditional looking charts, because people are doctors and nurses maybe don't like change, or certainly early adopters maybe don't. And so the thought of having a different format was a bit of a sticking point in our hospital. But certainly the traditional paper chart is visible in the electronic chart that you see there. And what can happen is anybody can phone anybody up and phone them up, and I can immediately get that chart up in front of me and see a wealth of data in front of me and have a meaningful conversation, whether I'm in a clinic or whether I'm actually in theatres or an anaesthetic room or in my ITU. Somebody during the day, at the weekend, in the middle of the night can phone me up and say, oh, I'm concerned about this patient. And I say, hold on, and I get the chart up and I can see exactly what the minute-to-minute OBS are for that patient, and have a meaningful conversation and a run chart going backwards. In addition to that, another benefit is that you can conglomerate scoreboards. And what I mean by that is you can create a virtual ward or a virtual hospital. And it means that you can get a rundown on a scoreboard of your top 5, top 10, top 100 sickest patients in the hospital. So rather than relying on individuals maybe at handovers and huddles to come to the meeting with bits of paper or post-it notes or memories from an hour ago of what the worst or the highest set of OBS were on a ward or even in the hospital, what we do now in the hospital is that we switch on a scoreboard. And at our virtual huddle that we have for the whole hospital every morning, we switch on this scoreboard, and rather than relying on individuals coming to the meeting and handing over what they've gleaned from a 7 o'clock handover in the ward to find out who's sick, we switch on the scoreboard and we can see live, top to bottom, the sickest patients in the hospital, and plans can be made or questions can be asked about what's being done for those patients. And suddenly that individual set of OBS from that patient can be seen not by just one person or 10 people, but can be seen by everybody in the hospital all at once, 100 people, 1,000 people, or however many staff want to dip into it. And that live scoreboard is constantly updated, and it doesn't need people to physically update it. The OBS system itself keeps that scoreboard live. So suddenly having a live scoreboard is extremely useful. In addition to that, we've got big television screens in every one of our medical handover rooms in all of the wards in our hospital. And what we have is a patient track live feed of that scoreboard that refreshes every minute, so that you can see as you walk into the medical handover room where all the handovers happen, the first thing you see in your face is that scoreboard of who the sickest person on the ward is. The benefits of that is that you can prioritize immediately, rather than jobs needing done or other bits of documentation that needs to be filled up or conversations that need to be had. The sickest top 10 patients on your ward are immediately in your face, pushed into the room so that it's unavoidable. And that requirement to click or log in or review a patient's set of notes at the end of the bed to see who is sick has gone, and it's now much more powerful, and that data is in your face as soon as you walk into any of the wardrooms in the hospital. And that immediately prompts action, because everybody will react when they see somebody that's sick. So what are the other benefits? Well, one of the things that we talked about is getting the validity, getting your OBS on time. If we don't do our OBS, then you don't pass go. If we don't do our OBS on time, then we don't pass go. Now, before we started this project way back 2012, but then when we rolled out in 2015, we did some analog audits of what our compliance rate on time and complete OBS were in the hospital, and it came out looking at I can't remember how many thousands of OBS we looked at, but it was a lot of patients, that our compliance rate on time was probably about or less than 50% once you'd taken into account those that were missed, those that weren't completed, and those were maybe inaccurate. And that was met with concern, but disbelief, real disbelief, in that they thought that the audit must be erroneous and something must have gone wrong, and you with the audit process, we're much better at our OBS than that, was the feeling. But then we introduced Patient Track, and we started measuring how many OBS on time and complete we were actually doing. And it turned out, when we looked at all the OBS, and when I say all the OBS, I mean 90,000 sets of OBS per month, it turned out that our compliance, when we switched on the machine first, was indeed about 50%. But quite quickly, we sent out all of these observations to the people that needed to know about it, and quite quickly, because everybody wants to do better, the performance got better and better and better. Without carrots, without sticks, the performance got better and better, and so our OBS on time crept up within weeks to 60, 70, 80, up to 90% and beyond for our OBS on time, and that's purely the power of the data. What else? Well, a couple of things that I've put at the bottom there are flags and patient specificity. And what I mean by flags is that because it's a communication tool, what you want to do is communicate not just maybe the early warning score, but other maybe important pieces of information. And the system that we've got, Patient Track, has a flag system whereby you can individualize bits of information such as DNA CPR or not for critical care, or even not for alerting for some patients that I was alluding to earlier on that might be for palliation. You might want to do eObs, but not alert hard to some of the phones. So you can put flags on that will mean that those alerts don't happen spuriously, so that you can target specifically the high early warning scores. And when they go off, you know that that patient is sick and it's not a spurious call. So by tweaking these things and dealing with flags and dealing with changing the bars on maybe the blood pressures and the heart rates and the post-op regimes for patients, you can make the system very patient specific, so that you make it much more specific and much more sensitive and specific, so that when you get a call, you know that this patient is someone that we need to be actioning and doing something about, rather than, I suppose, boy who cried wolf spurious calls, which is in the tight times that we live with limited resources of nurses and doctors, is something that we really need to make more efficient. So these are some of the bedded in benefits. But if we go to the next page, I'm just going to briefly talk about some of the importance of the data that I just touched upon there. And what I'm going to talk about briefly is feedback. And I don't know, there's a great book by a guy called Matthew Syed called Black Box Thinking that I highly recommend about feedback and systems and how to improve systems. But an analogy he makes is one about being at the driving range. Now, I'm not a great golfer. I'll hack my way around in 100 shots when
You've gone on mute, Gavin.
Hi there, can you hear me? I don't know how that happened. Yeah, I don't know how that happened. Sorry, I'm borrowing someone's headphones, but I don't know the analogy that was made. I was talking about a book by Matthew Syed called Black Box Thinking, which is really good, and it talks about improving systems with feedback. And the analogy he makes is about two golfers that go to the driving range, and the first golfer goes one night, and unfortunately, all the lights are out on the fairway, and so. The proprietor at the golfing range says, "Oh, well, you can have a bucket of 100 balls, but the lights are out, so I'll only charge you half price. That's fine." So the golfer went, "That's great. That sounds like a great wheeze. I'll go out with my 100 balls." And he goes and sets up his first ball, and he sets his feet apart, grabs the club, takes a swing, hits the ball, and he feels sweetly as the ball headed off into the darkness, and thought, "Yeah, that was a great shot." And then he does the same with the next ball and takes a swing, and the ball sweeps off into the darkness. And he feels, "Yeah, that was a great shot." And he does this shot after shot after shot. And after 100 shots, gets back in the car and drives home and pats himself on the back for having a great session. And all those shots felt really good. And then the next day, somebody comes along, the next golfer comes along to the driving range and asks the proprietor, "Can I have a bucket of 100 balls, please?" And the proprietor said, yeah, I'm going to have to charge you full price because the lights are back on. And she says, "Oh, that's great, no problem." And she goes out into the driving range and sets up her first ball and takes a strike. And unfortunately, the ball moves slightly off to the right-hand side. So what she does is she rearranges her right foot slightly and rearranges her grip slightly and takes another shot. And then that shot, she feels, "Well, I've hit that slightly thickly. So what I'm going to do is move my right foot back just a little bit and move my thumb round slightly, and I'll take another shot." And she takes another shot, and the ball just moves slightly to the left. And so she thinks, "Well, maybe if I just put my weight slightly forward onto my toes and I take my backswing a little higher, and I take that shot, we'll see how that feels." And that shot felt pretty good, and the ball went straight down the middle, but she still wasn't happy. And she did this shot after shot after shot. And for 100 shots, she kept making little micro changes to the system that she was using for hitting that ball. And by the time she left, she got in her car and she patted herself on the back and she felt that was a really good session. And I made some great improvements. And I think the point that Matthew Syed is making here is, if you don't have feedback on your systems, then there's no way that you can make appropriate changes and get live feedback on how to make those changes and be efficient in making improvements on a day-to-day basis. And some of the data that you get back from an eObs system is phenomenal. It's really good, and that's some of the benefits that you get in the feedback, which means you can make changes on a day-to-day basis, and not just on sample data from 10 sets of notes or 20 sets of notes. You actually have all the data for every patient every day and every week, to the tune, as I mentioned before, of 80 to 90. I think we're up to 100,000 OBS per month now, and we can see them all. And it tells you how many OBS are on time, and how many OBS are complete, and where those problems are. If you have wards maybe that aren't doing as good as other areas, and you can pick out the ones that are doing really well and feedback to the ones that maybe can learn from the ones that are doing better. In addition to that, it provides information of things such as chain length, which Gregor's talked about and I've talked about before, which is the time from when a patient starts deteriorating with an early warning score to the point at which they're triaged, i.e. they go to HD or ITU, or they're palliated and they stop scoring them, or you get them better on the ward. And what you want to do is reduce that chain length for any deteriorating patient on your ward, and the system automatically measures how long your patients have a high early warning score. And you can use that as a metric to decide, are your systems tight here? Are they getting better? In addition to that, other bits of information like how unwell are your patients? Do you know how many early warning scores you have on a daily basis? We had a huddle this morning, our scoreboard was up, and I saw that there was 9 patients that were red, orange, or had an early warning score of 3 or above, including the pediatric patients. So you can immediately see how unwell your hospital is on a daily basis, from minute to minute, from hour to hour. And even better than that, you can see where they're unwell in patterns. So not just right there and then, but conglomerate that over a month, a week, a year. And you can see where your patients are sick. Where's the hot spots? Where do we need to portion out our limited resource that we have in hospitals at the moment to be most efficient and act as a safety net to pick up the sickest patients in our hospital? Can we have the next slide, please? That's me going to conclude. It's a sharp run through of some of the embedded benefits that you might have for an eObs system. I think it's great. I'm biased, but I do think it's a very, very simple system, or changing our paper early warning scores into electronic warning scores. And I think it's the missing link in communication that can really turn our plans for deteriorating patients and ramp it up on steroids so that we can become really effective and really efficient with what we're doing in our hospitals.
Thanks so much, Gavin. I mean, that was a fantastic run through, and it's quite inspiring actually to hear what has been achieved in NHS 5 in a system that is now embedded. I've got so many questions. We'll leave that to the end, but particularly reflecting right now about the effect and the power it gives to your huddle system within your organisation as well. Okay, so I'm just going to move on now to our next speaker, Dr. Nicola Maran. Nicola is one of my colleagues in NHS Lothian, where she works as a consultant anaesthetist, but she's also the Associate Medical Director for Patient Safety within NHS Lothian and has oversight for all the national safety programmes. I've worked with her really since arriving in Edinburgh very closely around deteriorating patient, and Nikki currently chairs the deteriorating patient group within NHS Lothian. She also has a strong background in clinical simulation and set up and directed for a time the Scottish Clinical Simulation Centre. She has an interest in human factors, and I'm really interested in whether that interest has been useful as in this project, which is electronic OBS within NHS Lothian, a system that is just launching now. And Nikki has been very involved in many of the aspects of this project, particularly around testing. And it'll be interesting to hear what she has to say today. So over to you, Nikki. Thank you.
Thank you very much, Gregor, and thank you for the invitation to present some of our experience to date in Lothian with doing things a slightly different way and with developing. So rather than looking at one of the off-the-shelf options, we have actually worked within NHS Lothian to develop an eObs system that integrates into our existing electronic patient record, which is the track system. So can we move on to our first slide? So why eObs? So Gavin has already talked about many of the same things that we have found in Lothian. We have for a number of years had a very kind of comprehensive and reliable system of identifying and then reviewing our 2222 calls on cardiac arrests and medical emergencies. And what the learning from that has indicated that we have had some issues with our reliability around accuracy of news scoring, in particular a lack of reliability around frequency of observations and missed observations in patients who then go on to deteriorate. And it is often difficult to see good documentation around times of escalation. And we know that our documentation around special instructions for tolerances around chronic physiological changes in our patients are, again, not very good. And again, as Gavin has already alluded to, our SAE reviews and 2222 reviews often have indicated that we have failed to have a kind of shared oversight of the sickest patients in our hospital, in our department, or at a ward level, and to have a shared understanding of that. Next slide, please. We were keen, so there are a number of off-the-shelf options around electronic patient track and trigger systems, but we were very keen to explore whether it was possible to integrate the electronic observation system that we were going to use within our own electronic patient records, such that it was accessible within the EPR for every patient, which would actually make a lot of the kind of hardware and access options easier for staff. And next slide, please. We wanted to develop something, again, Gavin spoke about this, about really trying to make this feel like the current process and reflect the current processes, but happen within the electronic system, which has a number of the benefits that Gavin has covered and that I will also simply repeat that we've found within Lothian. So the processes around news functionality, we're collecting our data in the same way. We are entering the data into a tab within the track system, which allows us, which adds up the scores as we go. And we also have an ability to reset, to set our special instructions and to change the oxygen saturation scale within tabs, again within the track system. So it's all very easy and basically works the same way in terms of our data gathering and entry as our current systems. And again, next slide. And we have managed to create then a chart that really looks exactly the same as the paper chart currently that is at the end of the bed. So this chart completely reflects the News 2 chart from endorsed by the Royal College of Physicians, along with the extra fields that we had created within NHS Lothian for for entering data around urine output, blood glucose levels, circulation sensation, motor movement, and surgical drains. So So what appears in our electronic patient record completely reflects what is currently in the chart at the end of the bed for familiarity for all staff. Next slide. And so as Gavin has already alluded to, the benefits of an electronic eObs system are that addition. So when we enter all of the physiological data into the system, we may not enter it correctly, but the total score is always added up correctly. And then there are prompts then to as to whether or not it's appropriate to escalate the patient with access to any special instructions that have been set within the same frame in the track system. And then when you enter the data into the chart, you're presented with exactly the prompts that are available on the current paper chart around the actions that you should be taking to address any problems with the patient's physiology, such as applying oxygen, considering sepsis, and discussing with the charge nurse on the ward or escalating as appropriate. So we've got the prompts built in exactly the way that they are within the current news charts. Next slide, please. So what this system does not do is to automatically trigger. So we currently don't have the capacity to link this to to our telecom system, although this is a capability that we may be able to address in future. But what it does do is to make it very easy to use a tab to describe where the escalation call has been sent. So what grade of staff the patient has been escalated to, and what the clinical concern, whether it was news score, clinical concern, high lactate, or suspected sepsis, or any other reason for escalation, can be very easily documented into this tab. And then that enters directly into the clinical patient record. So it's very easy for staff to document that escalation. Next slide, please. So I'm just going to take control here of the slides, hoping this still works for people. And now I've got a terrible view. Sorry.
Thanks, Nikki. We can see your pointer there.
You can. The trouble is, can somebody remind me how I can make this slide bigger, because I can't see what I'm pointing at.
Okay, if you go to more, and then you go to some content, that'll give.
Oh yes, thank you. Thank you, Gavin. Okay, so so here we can see what the floor plan on our track patient record looks like. So this is a kind of what the floor plan for a ward would look like. And on our floor plan, we will have here the news score of the patient, whether or not the whether that set of OBS is increased or decreased from the previous set of OBS. There is a timer here that lights up when within 10 minutes of the next OBS being due, or that demonstrates that the observations are overdue for the time. There is an indication here of escalation. So this red icon, the red circle with the up arrow, means that the patient has been escalated for clinical response. When the clinical responder is actioning that call and alerts that through the escalation tab, this turns grey. So this is an indication that the patient's being dealt with by somebody, but not yet better. And when the patient is better, then that icon will be switched off. And if a patient is re-escalated, so there isn't a response within the allocated time, or there is a further deterioration and further escalation call, then that escalation icon has a black line around it. So gives us, from a floor plan perspective, an ability to see what is happening. And you can see in some of these, we've also got the TEP, the treatment escalation plan icon, is also available on the floor plan. So at ward level, that allows staff to have a really clear oversight of what is happening with all the patients on the ward. And then we have, as Gavin has talked about, an overview board, which allows us to see to arrange this by news score, so to identify the most unwell patients in any given area. And we can set this for a site, for a speciality. So we could set this for acute and general medicine, or for MOE, or for general surgery. We could set it by consultant, or it could be set by a single ward. So you can arrange and see who the sickest patients are in a number of different ways. And again, when you see this oversight board, it gives you an overview of the change in news score, the time and date of the last set of observations, whether there are special instructions in place, and the escalation status, and the treatment escalation plan if that is available. So that gives us that kind of consolidated view of all the information we might need to have to see the overall status of patients at, as I say, ward, consultant, speciality, or site level. And we can search for individual patients or individual specialties or consultants within this. And from this oversight board, just clicking on the patient's name will take you back to their EPR, and clicking on the news score will take us straight to that news chart within the electronic patient record. So it gives very easy access and overview the importance of that communication that Gavin was talking about for use at the level of the ward round, at handovers and huddles, and at site level. So if I can now just kind of so if I just a little bit about how we went about this. So the development of this project was absolutely led by Gillian Macaulay, who is our acute nurse director, and was part of a whole piece of work that she led around the model ward, getting all of the all of the good care around wards onto our electronic patient record. It was a multi-professional team, and we absolutely could not have done this without our eHealth colleagues, who have been amazing in helping us with the development, with nursing medical input across specialities and across the sites, our quality improvement support team, and our care assurance standard and quality improvement teams have all been involved in coming together to develop and test this. We've had regular weekly, fortnightly meetings to review findings of our testing at local and wider level. I'll come on to talking about that in a moment, and to have that kind of rapid learning and adapting to the challenges that we've identified. So rapid decision making, and we have also developed our measurement plan for use in both our testing and our implementation. As Gavin has already highlighted, the importance of that feedback around we've made these changes. Is this working? Is it doing, some true PDSAs around, is this doing what we predicted, and if not, what further changes do we need to make? And we've reported that and got approval for the various steps through our acute clinical management group. Next slide, please. So there have been numerous glitches along the way, and with obviously we have had to do extensive testing of this system. Mostly we have done that in the development environment of track. We have some challenges around the interfaces. So at the moment, we are still using computers on wheels to enter our data, and that presents a kind of challenge in terms of our interface. I'll come on to talking about that again in just a moment. And we have identified through our testing some issues with our current SOPs. And where we did, one of the things that we saw when we tested the system in the live environment was very quickly people saw what was available and just thought, this is brilliant, we want to use it. So we had some early adopters who we've had to keep an oversight of, and control of, which has been quite interesting. But it, in a way, just illustrates how keen the staff are to be involved in this. Next slide, please. So, as I say, we have tested this. In the development environment, we have tried out simulated low fidelity, mid fidelity using mannequins. We've tested on desktop. We have used simulation over and over again to test our hypotheses around how the system would work under different conditions, both with well patients and also with simulated sick patients, to test both data entry, actions, and response. And we've done that with multiple staff of different grades, different professions in different specialities, sites and contexts. And we have in the same way tested our training materials and our contingency plans for what happens if patients are transferred between areas which have and don't have the electronic record, and what happens if our electronic patient record were to go down. So we have used simulation in every at every level to test what we have developed. Next slide, please. So we launched our eObs system in one of our community hospitals last week in one ward. We have tested it on one ward during the week, again with multiple iterative feedback involving staff of all grades and professions, and yesterday have rolled that out to the other 4 wards on that site. A reason for choosing a community site is mainly that around the hardware at the moment, and the community sites do less frequent observations, so and we've got enough hardware there for the staff to have enough access to the hardware to be able to enter data onto the laptops and computers that are available there. Next slide, please. Our implementation plan involves scaling up through our other community sites, and then probably to our mental health hospital before coming into acute. And before we get into acute, we absolutely have to have a a better hardware interface option, so that with handheld devices. And we're also looking at the ability to directly interface our Hewlett-Packard Welsh Allen monitoring devices into the track system. We have also been reviewing our current escalation SOPs through our simulation testing. It was quite clear that we have our SOP is not well followed, and so we're having a look at our SOPs and testing some changes to the SOPs, and everything just involves regular review, revision and testing, and just being flexible. Next slide, please. So we couldn't have done this. It would never have started without the instigation of Gillian Macaulay, and she has been absolutely amazing in chairing the overview group. As I say, we couldn't have done any of this without our eHealth team, who have been patient and flexible in the extreme. Carolyn Swift and the quality improvement team, Lorna Turner, Laura Thompson, and the LACAS team, and Kenzie Smith, one of the charge nurses in our acute medical ward, and so many other staff across the system who have given their time to help us to develop a system that works for them and that works for patients. Thank you very much.
Thank you very much, Nikki. Wow, I mean, that's a huge project. And again, I've got lots of things I would like to ask you, and just really the granularity of those slides there that we can see and kind of envisage the system and how it's going to roll out. So it's really very interesting. What I will do now, guys, I know we said we may have a break, but we're slightly over time. So I'm going to go on to the next speaker. And I'm really pleased to welcome Karen Goudie, who is Chief of Nursing Services at NHS Lanarkshire at University Hospital Monklands. Karen's got a long kind of background in quality improvement. She was a Scottish Improvement Leader graduate, and she, prior to working in NHS Lanarkshire, she was doing older person health in NHS Fife. She has also undertaken the role of National Clinical Lead for Older People Healthcare Improvement Scotland, and she was involved in the early work around excellence of care. So she's got an excellent perspective, and I'm really pleased to welcome her to talk about the Lanarkshire experience, which was using Patient Track. Over to you, Karen.
Thank you. Thanks, everyone. Lovely to see some familiar names in the chat box as well. So it's nice to actually get out and about again, isn't it, and present some of the good work we're doing through these difficult times we've been having over the last couple of years. So first slide, please. I'll just move on. So thanks for that introduction. I get a wee bit embarrassed there when you were saying that. So I have been interested in early warning score and reliability around early warning scoring probably since my days in Stirling Royal Infirmary, where I was a hospital at night, ANP, and we used to team up with the junior doctors to develop an improvement project. And our first, one of my first improvement projects using QI methodology was around reliability of early warning score overnight. And that experience kind of came around when you're a new ANP with the FY1s, you know, finding patients in quite a state of deterioration. You know, what else could we do to kind of capture these patients earlier on? And that's where we carried out our first MQI project. So I've been interested in this for a long time, and got the chance to kind of influence what we do here at NHS Lanarkshire. Also lucky enough to have worked with Gavin Simpson in NHS Fife, and that's where my interest in Patient Track kind of was born. Gavin and I worked together looking at frailty and delirium with the team up in Fife, and how we could use the system just to identify some of those signs of deterioration in older people. So the drivers I don't need to explain to the people in the room, but one of the important drivers for us here in NHS Lanarkshire is the new Monklands Hospital. So the ambition for that new build, it's going to be one of the largest capital projects, you know, after the QE in NHS Scotland, is to be a fully digital hospital and carbon neutral hospital. So this is where we had the opportunity a couple of years ago to think about what digital solutions can we test in the live environment, and Patient Track was one of those kind of innovation projects that we put forward to test here on the Monklands site, but obviously thinking about how we could spread that improvement across our NHS board. Next slide, please. So being a brand new chief nurse, you know, in partnership with the chief of medicine, we obviously have a huge part to play in terms of looking at reliability of systems, quality and safety, but also reviewing SAREs and commissioning SAREs when things go wrong across the site. And one thing that we were picking up quite quickly after I arrived was around that kind of lack of recognition of deterioration across the site. So it made us go and have a look. And we carried out some measurement using the SPSP bundle around reliability, around early warning score, and just a bar chart here, just detailing the bundle compliance across the hospitals. So 27% reliability across the bundle elements, and that was not an easy, you know, finding to then go and report to help people understand that we had a real problem here, and how did we understand and unpick where the kind of human factor issues were, or what was the barriers in terms of escalating patients, particularly in the out of hours periods, is what we picked up in the measurement piece that we carried out. We use a system in the NHS Lanarkshire, which I'm sure many of you use, care assurance systems that will use methodology of sampling, you know, notes or sampling process across your wards, and ours is called LandQuip. And when I looked on that, the entire site here in Monklands looked as if everything was fine, you know, everything was either 95 or 100% reliable. But actually when we looked and used some QI methodology, but also sampling that was precise, and using people that didn't work in those areas as well, I think that was quite important, that the findings were very, very different. So also revealed that we probably had a bit of false reassurance in our system around process measurement, around early warning score reliability, particularly around frequency and accuracy of early warning score. So this in turn, you know, gave us a problem that we had to deal with, but the timing was just perfect because MRP, the Monklands Replacement Project, was just kicking off, and we were looking for innovation projects. And fortunately, we got the go-ahead to test patient track in a couple of wards here in Monklands to see if that was a particular piece of innovation that we'd want to take to the new digital hospital for the new Monklands. So next slide, please. And what we found, you know, through that measurement piece and through discussion with staff is, you know, the ability to recognise deterioration, confidence in those staff members around, you know, the human factors, what we were doing at our huddles in terms of talking about people, the sickest people in the building. Did we actually talk through that? And certainly my experience working with Gavin and Fife, you know, the whole hospital huddles there, the first thing that was always spoken about was who's the sickest people in the building, and you know, the response to those individuals was the first thing that was spoken about. So we worked to try and develop that conversation right through the whole hospital huddles as we pause as a clinical team throughout the day, and I'll go on to talk a wee bit through that. So again, just looking at, you know, how things fall through the net. We all know about this around frequency, inaccurate observations, scoring that wasn't accurate as well was another piece, and patient harm would be that kind of end point. And Gavin spoke eloquently about the communication piece, and I guess that's what we found, that communication was one of the biggest barriers in terms of that escalation and ability to recognise, you know, where the sickest people were across the site, despite having an outreach team through our HEC team, despite having, you know, good presence at the huddle from anaesthetics and ICU, we just needed something extra. So the test went forwards. Next slide, please. Thank you. So this is just some screen grabs from Patient Track. So Patient Track's the system that NHS Fife use and NHS Lanarkshire as well. So we started the test with 4 wards here in Monklands. I'll go on to describe some of the measurement we use. Right up to today, where eObs is now fully implemented across all 3 acute hospitals. And also we will be spreading the system out into some of the community sites as well, so that we've got that whole oversight of NHS Lanarkshire, if you like. In terms of Monklands Hospital, we also embarked on thinking about what could we do differently in terms of whole system, in terms of our huddle. So the picture on the right-hand side of your screen is our command and control centre. So that's where we pull numerous pieces of intelligence across the site. So things that you'll all be familiar with. So track care, our bed state dashboard, the ambulance arrival screen, Opera's in there as well. the floor plan for ED, but also we've added in patient tracks. So now we can see the clinical measurement piece as well as the operational piece in terms of running the hospital day to day, but also making sure that the plans that we need to put in place for teams to respond to are known by everyone. And that's done through kind of rapid conversations through the huddle. And I'll talk about that a wee bit later on. But you'll see here a wee screen grab from patient track where the patients, you know, are visible, and we, at the same as Gavin, the same as Nikki, we will put up that information, that intelligence first thing in the morning, talk through the sickest patients. You know, roughly we had about 10 patients scoring a red or an amber this morning. The team are then able to reassure me or whoever's leading the huddle that that patient's either been reviewed overnight by HECS and ICU are involved, or there's a plan in place and we're waiting for treatment to end and discovering, you know, what other things we need to do or referrals that are required in the morning. But also if that patient is end of life, that the team can then flag that patient to us, so say that that patient's end of life and not for observation, that we're able to then make sure that we are not continuing treatment and care that's not appropriate, particularly when people have got TELPs, etc. in place and DNA CPR. So all of that information is flagged by the nurse and staff and handed over in the morning by a rapid review of those patients. Next slide, please. So here's the system itself. So what I'll explain a wee bit so people don't know. So the nursing staff traditionally would have had the paper-based system. So we've now moved to an iPads in every ward area, or any tablet. We can use other tablets. I suppose I shouldn't be mentioning Apple, but I've just done it. So we use iPads across the site. So observations are put into that iPad, etc. And then the nurse will be given, you know, that detailed kind of summary of people's parameters. And the system itself, you know, is pretty foolproof. So if you haven't done anything, or, you know, a patient needs their observations done in a particular time frame, we've set those parameters working with the company, that the nurse will be alerted to that. So it kind of removes that issue around not doing OBS on time, because the alerts will be there to remind people to go forward and do that. Next slide, please. So we wanted to try and push it a wee bit further. So I had a look around about what else could we do to make this kind of process more efficient. So measuring the kind of test wards and looking at reliability and the improvement in reliability. I'll come to that data later. We started to think about releasing time back to nursing. So someone's mentioned that earlier on. So bringing in some efficiency of process, does that actually give us more time for nurses to, you know, focus on other aspects of care that we need delivered in wards? Now, some people that are maybe interested in what money we're spending thought that, you know, does that release more nurses? We won't need as many nurses. So those conversations were a wee bit tricky, but we got through that. So what we did find out in the market was a observation monitor that links directly with patient track, so that when the nurse inputs the observations, that it's done through a Bluetooth technology. So as soon as those observations are taken with this monitor that you see on the screen, it's automatically ported into patient track. The nurse will have the iPad there, the score will then be revealed to the nurse. So it actually takes time away from the nurse to input. So we move from one stage of input to iPads to automation from these monitors, which are in Welsh Allen, which I'm sure some of you have, and NHS Forth Valley have certainly moved to them. So it removes that kind of need for human entry and transcription error. There's a real potential around remote monitoring, and the respiratory rate technology which is built into this monitor is pretty efficient in terms of just picking up deterioration in respiratory rate, which is one parameter we know we have some issues with. So next slide, please. So I'll not go through this slide entirely, but if people have got questions, or they can go and read the article that was published. We started to look at what time we actually saved. So we were very lucky to have Dr. David Watson, who's now the chief nurse over at Wishaw now, who led some of that study along with Martin Carberry, who was our nurse consultant here in NHS Lanarkshire for critical care. So you can see the numbers there. You know, we save thousands of hours in terms of extrapolating that data up into a whole hospital. So the measurement across those 4 test wards, you can see there, saves, you know, 28,000 minutes in terms of nursing time. So I know there'll be nuances in there. However, there's, you know, the feedback that we got from staff, you know, we've questioned all the staff through quantitative methods. You know, how did this system work for you? Did you feel it was safer than the traditional methods? And some staff members, some laggards that, you know, quite like the paper, but pretty much the whole system is now embedded with electronic eObs, and the staff are definitely happy with that. I'm just going to pause a wee second because somebody with a very loud voice outside my office, and I'm going to shut the door. 2 seconds. So sorry about that. She's got a lovely voice, but it's a wee bit loud. So this is just some of that data, and that data is published. So next slide, please. So you'll see just the headline of that study that was published with from Martin and David. And I think one of the most important things around our implementation piece and the testing here on Monklands Hospital was around that bedside teaching, and a bit like simulation, etc. that Nikki was mentioning, that, you know, having this system is an absolute advantage. However, what we really need to work on with that, in tandem with it, is around the expertise of the nurse within the ward around recognising deterioration. Martin and David's carried out one-to-one teaching as we were implementing patient track in these wards, just around touch, feel, look, ends of beds, glance at that patient, that, you know, the parameters are important, but how you then weave that information with your clinical judgment and then take that information to the escalation piece. So if they're escalating to our kind of outreach team or escalating to medical colleagues, that the correct information was given in a very succinct SBAR style way, that it wasn't just the news score. So we put that training in across those wards when we started the implementation. I think that'd be really important for anyone that's thinking about doing that, and we can share any of that work if that's helpful at all. Next slide. So our obviously our aim in terms of our improvement aim was to reduce variation, particularly around the early warning score SPSP bundle. So we looked at our compliance rate in the early tests, and we moved from a 27% reliability to 72% in quite a quick pace with the introduction of electronic eObs, and also had proven that, you know, was an estimated time reduction for the nurse or the healthcare support worker in terms of delivery of that process. So these are the wards underneath. The data's not great because it's in a bar chart, not my favourite, but again, we can share that, and it is published work. So David would be happy to catch up with anyone that wants to kind of find out more about that. Next slide, please. So I thought I would mention, I know this is an eObs webinar, but I thought I would just mention some of the next steps for us here in Lanarkshire, just around the capability of this system, around deterioration and a number of clinical conditions. So as a system, we have purchased a number of the tiles from Patient Track that have some capability that's really exciting. So AKI, and for example, has been used by one of the English hospitals that use Patient Track down south, and there's a study that's been published around the ability to track and trigger patients that have deteriorating renal function within an acute hospital, and Patient Track links directly with LIMS to be able to do that. So our next kind of phase of Patient Track implementation and bringing that into the command centre around really understanding, is there deteriorating patients in terms of renal function across the site. Another tile that's of great interest is the diabetes tile as well. So the bedside monitoring that we test blood sugars at the bedside, that Bluetooth technology links again with Patient Track to track and trigger particularly patients with diabetes across the site, where you can absolutely, the consultant can go into that record, get a record of what's happened to that person's blood sugar over a period of time, can even look at it from home on their mobile device, just to see the stability of that patient as they come through the system. We are working on the sepsis tile, it's nearly there, again, just around the usual bundle requirements from national colleagues and from the evidence around how we manage sepsis, and PVC. So I know NHS 5 have the PVC bundle, and we're about to launch that on the Monklands site in the coming weeks. And you'll see there's a number of tiles there that we've taken on that will be quite exciting to see the outcomes of them as we test them and implement through the system. Next slide, please. So this is just some screen grab of the AKI status. I think this is of real interest, and the study is down below for folks that want to have a wee look at that. But again, just that ability, and it's Western Sussex hospitals that took this forwards, the ability to just track those patients in terms of deterioration. And we know that this is an improvement aim for us nationally as a health system in Scotland, and the ability to do this electronically and automate that, and then using that alert process through Patient Track to let clinicians know if there is any deterioration within their patients, no matter where they are. And you know, certainly we're a district general hospital. We have a lot of patients right now that are out with their speciality. So this gives the consultants and the clinical teams and the ENPs the ability to follow their patients no matter where they are, because that consultant tag will then be able to kind of bring that information together so that people can quickly see how their patients are doing. Next slide. And this is just the other chart. So the diabetes chart you'll see on the left-hand side. Sorry, it's a wee bit blurry. It was a bit of a screen grab. And on the other side, we've also got fluid balance. So electronic fluid balance, another process that we know in hospital is, you know, frequently not done particularly well when we measure it. And again, linking directly to the AKI work and, you know, dehydration, food, fluid, nutrition in hospital. So again, can give you kind of automated process reliability through this system, you know, for your care assurance needs, but also understanding, you know, is there particular ward areas that need a bit of support? Just like Gavin said, you can start to triangulate some of this outcome data through the patient track system to understand if you've got any issues and if that links up with safe staffing, etc. Next slide. So our kind of ambition now is to kind of look at that whole system, big data, and, you know, Gavin again had mentioned that we've recently just pulled some data for the Monkland site. Now things have been pretty fraught in the acute hospitals, I'm sure people are aware of lately, and actually starting to understand if there are missed observations through patient track, we can get that data immediately. We're currently building our dashboard, which should be live in the next few weeks, around reliability of processes, which links beautifully into the excellence in care work nationally for Healthcare Improvement Scotland, obviously, to have insight into how areas are doing. And just thinking about the opportunity to pull all those big clinical pieces together in terms of our command and control, but also to create that assurance piece across the acute hospital, that data is reliable, automated, and, you know, taking away that ability that's paper-based measurement and, you know, spending a lot of time measuring things, maybe not in the most reliable way. Next slide, please. That's me. So happy to take any questions. Like,
Thanks
quick
very
run
much,
through
Karen.
a lot.
Thank you. Thank you. Well, I mean, 3 fantastic talks there going over eObs from a number of different angles, and I've certainly got lots of questions. If you do have any questions for our 3 speakers, or even from others that may well be in the chat, please put up your hand and we'll get you. And we should have a good 15 minutes to talk, or 10 minutes to talk about questions. If while you're having a wee think of any particular questions you may wish to ask, I was wondering if I could bring in Gillian McCauley, who, as Nikki mentioned, led the project in NHS Lothian, and I know, Gillian, you were involved with NHS Lanarkshire as well. The Lothian project sounds very complicated and complex, and is being rolled out as we speak. What was the main driver for you in terms of the importance of electronic observations for our patients?
Thanks very much. So sorry I couldn't join to hear all the presentations, which is a shame. Our main driver actually came from developing a new care planning system. So ahead of the eObs project, we launched person-centred care plans across 130 wards last July, and that is linked to the eObs project, which was a subgroup of what we've called the model ward. And I think for me, what we've done is link our care planning system to our care assurance system, and therefore the eObs project is part of that. So now we get our observations that are recorded electronically appear on our person-centred care plan, and that is under the section of deteriorating patient. So for me, it was about linking all the pieces together to make sure that the care and treatment, particularly nursing care of a patient, is done in a person-centred way, recorded in a person-centred way, and managed in a person-centred way.
Thanks very much, and very similar to what I think Gavin was saying in terms of that visibility of data as well being absolutely key. If I could come just looking at the chat there, Wendy Russell, I know you posted in the chat. Would you be able to just come in and tell and kind of put us your question for Nikki, please?
Yeah, sorry, I actually had quite a lot of questions. We in Esh and Aaron are keen for eObs, so I'm just trying to steal as much knowledge as possible. So my first one, I suppose, was for Nikki, was about the time it takes to input. I'm just thinking of our hospital with very few laptops with track care, how much time does it take an individual to fill out the observations on a track care system as opposed to the paper-based system? Is it longer, shorter, more equal? Because obviously the patient track was an automatic pull, so I'd be interested to see if that was more efficient or not.
Yeah, so from our simulation testing, the time taken to actually document, to put in the numbers, is longer on the entering into the electronic system, but the addition bit is the bit that takes the time, because then going back and adding up, actually, if you looked at time to enter the observations, it was longer on the electronic system. But if you look at time from start of observations to a correct news score, it's almost exactly the same, even using a rather clunky interface. So that will be considerably reduced when A, staff are used to using the system, and B, more importantly, we have an easier user interface.
Can I ask my follow-up queries or not?
Go for it.
Okay, so the other thing I'm interested in is the automated element that some people have. So there's an automated alert directly to someone when a new score is high, and the pros and cons to that, because I'd read a paper somewhere that suggested that the loss of autonomy from a nurse then picking up the phone and having a discussion with someone, or being able to put some management in place, was lost. That feeling of kind of responsibility was lost when it was an automatic thing. And then do you then have an automatic team? Everywhere will obviously have different models, but if you have a team that then goes to all the high news scores, they take time to triage and decide who to go to. Does it take longer for them because they don't know the patients? I'm just thinking of the pros and cons of different models of automated versus still going, a person-to-person discussion.
Thanks, Wendy. Apologies for the thunderstorm that is above me in Edinburgh here, but can I get Gavin to pick up on that, please?
Yeah, no, great question, and a very important one. We've got a kind of hybrid, so we've not got holistic paging alerting throughout the hospital, and that's kind of rolled out organically. We originally started it in hematology, and we picked there way back because they were very good at taking their obs, because they had so many highly acutely unwell patients and things, so there's variability there. The benefit of it is there's a hierarchy system in the alerting protocol, so that after it alerts first of all to whichever team you want to put in as your first responders. But then if you don't get response after 15 minutes, it goes up a scale, and it alerts maybe the FY1 and the ST, or the FY1 and the consultant in some areas. Or if it's hospital at night, it alerts first of all the hospital at night, and then if there's no response after 15 minutes, the hospital at night, and then it'll do two pages to the next tier up the ladder. And there's a little stethoscope on the system that you click to say, I've got this, and I've responded to this, so that the system shuts down. And that's a kind of fail-safe. So if someone leaves a page in the toilet or whatever else, there's not a sick patient at the end of it. Also, in addition to that, it doesn't take away from nurses phoning as well. So we've not said this is the system and you must follow this. It's kind of an additional add-on in some areas. But I suppose the benefit of it is, the example I would give was one of my colleagues in hematology. A patient was getting a new chemotherapy, and they were over in the labs, but all the consultants in hematology wanted to be CC'd into those alerts for their patients on hematology. And I got an alert through the huddle, actually, and also we have a phone as well, and I got that alert, and we both responded to it. And by the time so the obs got taken, the early warning score was up, the nurses were in the bay dealing with the patient, and by the time we got up there, I got up there at the same time as the consultant hematology, who was in the labs doing some lab work. We'd both come straight there, and we both arrived at the end of the bed because we'd simultaneously got calls. So I don't think I suppose we're seeing it as an augment rather than a replacement, absolutely, in some areas. Conversation-wise, the onus is therefore on the receiver to make the phone call back to the wards to have the conversation with the ward to say, well, I've had an alert about specifically the patient, not which patient. It's Mr. Johnson in Bay 4.
been alerting on my phone. Can someone tell me what's going on? What do you need? And that's a kind of triage. So rather than limited staff at night and the weekends having to maybe go all the way up there, they can have a conversation, I suppose, if it's the other way around in a direct phone call, but they can do some triaging over the phone, the OBS chart in front of them. So I suppose it's optional. We've got a hybrid in different areas in the hospital. I think using the system to make it patient specific so that you get rid of the boy who cried wolf is really important, so that you don't get spurious calls, so that you know when your alarm does go off, then the patient.
Thanks very much, Gavin. If I could just bring in Karen, you mentioned the Welsh Island devices that you use in NHS Lanarkshire, and obviously Lothian are looking at that for their acute sites. How important do you think it is to use these kind of automated devices in terms of saving time at the bedside and freeing up time to care?
Super important. You know, there's been some stumbling blocks around the implementation of those monitors, just the Wi-Fi connectivity and Bluetooth connectivity, but we've kind of ironed out all those problems. But the feedback from the staff has been overwhelming around, you know, the ability to very quickly carry out the observation task, but then have that reassurance that it will flag up somewhere, either through clinician alerting or in the command centre. So yeah, it's definitely been a benefit for us, and we're rolling those monitors out through the acute system in NHS Lanarkshire now.
Thanks very much, Karen. Well, thank you all, and thanks for those who asked questions as well. I think that's been a really useful session, and I think just mind all still on the call, just to thank all of our speakers in the now time-honoured electronic way with those clapping hands. I think if we go to the next slide, please. We're just going to pop some a feedback link in the chat there, and we'd be really grateful if all those attending today can fill that out, please. Next slide, please. Before I take you to a number of next steps, I just want to try and pull together everything that we've heard today. I mean, I think from all three of our speakers, we've heard that although this webinar ostensibly has been talking about electronic observations, it's really been focusing on understanding patient deterioration. And at the heart of that is knowing your data, and everyone who needs to know your data, knowing your data. Something that all three speakers have spoken about is communication. And in these fraught times when our system's under stress, I'm really struck by the impact it has in terms of communicating within your team, but also over the entire hospital, and really supercharging that huddle so all can see the real live data about where your sickest patients are. And that clearly appears to have implications in terms of saving time to care as well. So that's been really interesting. Before you go, I'd just like to highlight the SPSP National Learning Event, which is taking place on the 27th of September at Murrayfield. SPSP leads are coordinating in-person attendance, but there is virtual attendance as well, and you can register by clicking on the link on the slides. Just another reminder that there are resources regarding deteriorating patients on the iHub and on our MS Teams page. That includes our mapping tool and simulation tool for structured response to deterioration. And for those of you who are at our network event last week, there's also the resource pack regarding cardiac arrest, both data collection and learning from cardiac arrest. Thanks to all three of our speakers from today, and thanks again for a very productive webinar. Thanks again. Bye now.